Welcome, everyone. We do not want to take advantage of the generosity of your time too much. So it is 10:02. We will begin our press conference. And first of all, I want to thank Nathan Kelly, Nathan Stoll. Dr. Stoll is from Mount Sinai, as you know, and he's joining me today. And there are other experts that are joining today in the event that we continue the discussion after Dr. Stoll and I introduce and discuss the topic with you. The way we will go about this is first, Dr. Stoll will present to you data, solid, robust data that relates to the situation in long-term care homes and his views on where we are heading to. After that, I will share with you the views of RNAO, both very briefly on pointed data about the province as a whole, not related to LTC, and then specifically to LTC and our projections, both for the province and LTC. And we will follow by what we think have been the improvements between wave 1 and wave 2, and what have been the areas where we are completely failing between wave 1 and wave 2, where we have done no actions. And then we will end with RNAO's asks for the go forward immediately. The go forward is not in a month, it's not in December, it's immediately. And we will open for questions only from the media first. So Dr. Stoll, the podium is yours. The podium, the Zoom, the mic, the slides.
Yes, thank you, Doris, and thanks to everyone for joining. Really, Doris and I connected because we are both quite alarmed and concerned about the intensifying and worsening situation within long-term care during the second wave. There are many people speaking specifically about the state of our healthcare system as it pertains to ICU beds and hospital capacity, but it's really, really critical to keep the focus as well on long-term care. And I will show you some of the epidemiology as it relates to the COVID-19 pandemic in long-term care, as well as some of the research that our own team has done on risk factors associated with both outbreaks and the spread of outbreaks within long-term care homes. Just gonna make this screen big. I call this our provincial shame, COVID-19 in Ontario long-term care homes. We can also speak about our national shame, as I'll show you as well. But let's focus on Ontario. I'm gonna talk about three things briefly. The epidemiology of COVID-19 in Ontario long-term care homes. What are the factors associated with the risk and spread of COVID-19 outbreaks? And then a little bit about bias in healthcare policy during the pandemic and why we may not be seeing the action we need within long-term care homes. So this is data I pulled this morning. It was from yesterday. This is the distribution of cases. This is one of the, I would say, one of the things that has plagued the pandemic response as it comes to older adults and long-term care home residents. So see the majority of cases. The red ones are active cases, the resolved ones are green cases. The vast majority of cases, almost 80%, are under people under the age of 60. This is what we heard early on in the second wave, that it's in younger people, it's not going to affect older people. We have protected and put up the iron ring again around long-term care residents. But who is bearing the brunt of this pandemic? 95.6% of deaths have occurred in Ontarians over the age of 60. That's a finding that's consistent nationally. You'll see that this is a disease that disproportionately impacts older people, and particularly those that live in long-term care. So almost 2/3 of all the deaths in our province have occurred among long-term care home residents. This is the epidemic curve of deaths in long-term care homes. You saw we had a absolutely devastating and catastrophic acceleration of deaths between end of March and May, where we had almost 2,000. We approached 1,800 long-term care residents. But you see, end of October, we are starting to see that take off that accelerated and almost and approaching exponential growth of deaths within long-term care homes again. And so this is why we are calling for urgent action within the sector, because we cannot have this happen again, what we saw in the first wave. And we've had, as I'll show you, 200 deaths since mid-September, 200 deaths within our province's long-term care home residents in the second wave. People ask all the time, why are long-term care home residents getting infected again? Why is this happening again in the second wave? The causative agent of COVID-19, the causative infectious agent is SARS-CoV-2. Long-term care home residents are at high risk of contracting this. We've known this. This is a figure since March from Washington State, which had the site of the first COVID-19 outbreak in the United States. Long-term care residents, they're in congregate living, as I'll show you, often in outdated facilities. They have exposure to staff who live in the community where we know COVID-19 is surging right now. I put "and visitors" in brackets. There's actually no evidence to date that visitors or caregivers have actually contributed to the spread of COVID-19 into the homes. Doris will talk about the way that we have imposed restrictions on visitors and shut them out throughout the pandemic. And these individuals are sick individuals who live in long-term care homes. They have increasingly become more complex over the last 15 years. 70% have dementia, 90% have cognitive impairment. Many of them require extensive support for their activities of daily living, things like bathing and dressing. And that makes it also challenging for them to do the things we're all being asked to do, like physically distance, wear a mask, and have hand hygiene. So that's why they're at such increased risk of contracting it. And of course, when they do get infected, they're, as I showed you, they're at increased risk of mortality. So it's not just advanced age. As you age, there's a phenomenon called immunosenescence, where your immune system becomes less robust. But you also accumulate comorbidities as well. And these comorbidities are things that also place them at increased risk of death. We've seen case fatality rates in the first wave approaching 30% in our province. In other jurisdictions like Washington State, it was about 1 in 3 residents who died. So it's somewhere between 1 in 4 to 1 in 3 long-term care residents that get COVID-19 go on to die. And that's why this is from the Camilla Care in Mississauga from the first wave. You saw these catastrophic fields to remember the deaths of people that have continued to accumulate inside our long-term care homes. If you look nationally across our country, this is from the National Institute on Aging Long-Term Care COVID-19 tracker. I showed you about 2/3 of all deaths in our province have occurred in long-term care homes. This is all residential care settings. We often forget about retirement homes and group homes, other sites where there is congregate care being provided. We'll see Ontario, it's about 70% of deaths if you take those into account. And nationally in Canada, 76% of all our deaths have occurred in retirement or long-term care homes. Ontario and Quebec have the dubious distinction of leading the way. Ontario with 2,200 deaths. Again, that includes long-term care and retirement homes, and Quebec at 5,200 deaths. But we are seeing now in provinces like Manitoba, in provinces like Alberta, this is not just an Ontario issue, that deaths are taking off nationally as well. And we do have the dubious distinction of having, out of all countries that we have data for, you'll see this is the outlier, Canada. This was from the first wave when it was about 81% of all our deaths occurred in long-term care home residents, the highest proportion of all countries we have data for, really reflecting the lopsided pandemic response that we have had and the real failure to protect vulnerable older adults. Some have talked about the real measure of a pandemic being excess mortality. And excess mortality is the excess in deaths that one has experienced during this pandemic year in excess of historical trends for mortality. You'll see in the yellow mustard color, this is the 5-year sort of rolling average of what one would have expected to happen in our long-term care homes if there was no COVID-19 pandemic. Everything above that is the excess mortality we've experienced this year. And this was through June 29th when the coroner actually was collecting deaths, both COVID and non-COVID deaths. So we had a lot of individuals who died of COVID-19, but we also had a lot of individuals who died of non-COVID-19 deaths because of the conditions within long-term care homes, where even if you didn't get infected with COVID-19, there was a collapse of medical care, there was collapse of direct care being provided to people. And largely or almost entirely family caregivers were shut out during the first wave as well. So there was non-COVID death that occurred as well because of the conditions of the home and the collapse of care around them. This is data that I tweet every day. I probably usually would be tweeting it right now because the numbers probably just came out. But I have been just tracking daily just for the world to show, because it's not necessarily featured in the same epidemic curves that you see. The orange are and there are other individuals who I think are on this call, like Sue Gowans and Michael Yakovos, who have been diligently doing this as well, just to really bring attention to this issue and how critical it is that we cannot lose focus and just use the metric of ICU beds and hospital beds, which are of course important, but we also need to think about our frail older adults when we talk about public health measures and what needs to be done. So there are almost 700 now resident active cases in our province. I showed you that the case fatality rate from the first wave is somewhere from 1 in 4 to 1 in 3 residents. It's not hard to do the math there, that we're probably going to expect a lot more tragedy in the coming weeks and months, even with just the number of residents who are infected now. We have 435 staff that are infected. That's not only at risk to their own health from them being in the front lines, but they are also at risk of transmitting it to the residents they care for. And we've had 200 deaths since September 14th in our province. So that's brought us over 2,000 deaths within long-term care homes. And there's 94 homes that are experiencing outbreaks right now. The numbers are taking off that you can see over the summertime. Even the beginning of September, we were doing quite well. And as Doris will talk about, we failed to act on many of the things that needed to be done to prevent this from happening again. My own research, what are the factors with the risk and spread? And this relates to some of the things that Doris is going to talk about. We looked at long-term care homes. One of the issues that we kept seeing was the issue of for-profit status. And we looked at data. This is published in the Canadian Medical Association Journal from the real peak of cases and deaths in the first wave. And we looked at 3 outcomes of interest: COVID-19 outbreaks, the size of a COVID-19 outbreak, the number of resident cases among homes with outbreaks, and the number of deaths within homes that had a resident case. What's important to note here is that about a third of there were about 190 outbreaks. So there were 190 outbreaks in homes. So about a third of all homes had an outbreak. The case fatality rate in our province was 27.8%. So not too far off what we saw early on. Again, this was to the end of May. There were 1,452 deaths. We know we're at about just over 2,000 deaths now. So we've had a lot more tragedy since then. Really want to emphasize this first point, that the odds of an outbreak were not associated with the for-profit status of the home, but they were associated with the incidence of COVID-19 in the public health unit region surrounding a long-term care home. So that is critical to consider now, because we cannot prevent outbreaks in these homes without suppressing transmission of COVID-19 in the communities. It's not about the profit status of the home. It's about the incidence of COVID-19 and the transmission in the communities that surround homes. And that's where we need to focus upstream to prevent outbreaks from happening. But what we do know is when it does get into the homes that were for profit were associated with larger outbreaks, nearly twice as large, and they had 78% more deaths. But it wasn't all for-profit homes, and it's unfair to paint the whole sector with the same broad brush. What's really important also is that when the virus gets into the home, though it was those homes that had older design standards and chain ownerships that were the ones that were that saw particularly large and deadly outbreaks. And so these are the homes that we really need to be focusing on, the ones that have older design standards, chain ownership, and to really be specific about the risk factors that we identify here. It is true that there are more for-profit homes that have older design standard and chain ownership, but again, it's not the entire sector, and it's important to consider that when we think about looking at our surveillance systems and which homes we want to target for intervention. The other piece of research, which was just published this week in JAMA Internal Medicine, it was released earlier on a preprint server, was we looked at nursing home crowding. This is another critical issue in the pandemic right now. We use the same cohort of residents. We built something called the crowding index, average number of residents per room and bathroom. So if you had a home that had every resident had their own room and their own bathroom, that would be a crowding index of 1. Of course, we don't have any homes like that in our province. But if you had a crowding index of 4, you'd have 4 residents per every room and bathroom. We do have homes like that in the province, and that's the issue here. So we looked at the cumulative incidence of COVID-19 infection and mortality, and then the negative tracer we did not expect this to change was the introduction of COVID-19 into a home. What we saw was a very strong correlation between crowding in the home, so more residents in multi-occupancy rooms, and deaths and cases within the home. And what we did was simulations that suggested that if we could convert all 4-bedded rooms to 2-bedded rooms, we would have averted about a 5th of all cases and a 5th of all deaths. And that's really important because in June, there was a directive put out to limit admissions to no more than 2 residents per room. But what that didn't pertain to was the people who were already living in those rooms. So there's still, the majority of these rooms are occupied with multiple residents. And what we have seen in this second wave is that a lot of the homes that have had these explosive outbreaks that have been very hard hit continue to be very crowded. And it's an important risk factor that needs to be urgently addressed, particularly as the COVID-19 surges in our communities. So in the last couple of minutes before I hand it off to Doris, I just wanted to talk about why I believe that we are not seeing some of the action that we need right now to protect our most vulnerable, some of the bias that is plaguing our healthcare policy in the pandemic. So one of the things that I really assert is being proposed here, although it's not being stated overtly, is that there is a concept of trying to shield or use a focused protection strategy. And this has been stated in different ways, I would argue, by the government, talking about things like the iron ring. When you look at the tiered framework of the province, they talk about protecting vulnerable populations. And this is the fact that you attempt to segment the oldest and most vulnerable while allowing everyone else to resume some normalcy to their life with simple hygiene measures like masking, physical distancing, and hand hygiene. Our research clearly shows that the strongest risk factor for an outbreak is the community incidence. And we also know that prolonged isolation of large swaths of the population, like those living in long-term care homes, we have over 70,000 people living in them, and that's not including the tens of thousands more that are in retirement homes and other congregate care settings, is practically impossible and highly unethical. And so to speak more to the impracticality of that, if you actually want to shield long-term care residents from COVID-19, you'd also have to shield the more than 100,000 long-term care workers who live in the community where the virus is surging. And not only that, these long-term care workers, as we know, have historically been underpaid without full-time jobs, without necessarily sick benefits, and they come overwhelmingly, they're overwhelmingly women and women of color who may live in places like multi-generational homes and in the COVID hotspots of our city and our province. So it's practically impossible to be able to shield long-term care residents. You would need to shield nearly 200,000 people. We also know that empirical evidence from other countries shows that it just doesn't work trying to restrict uncontrolled outbreaks in particular sections of society. If you let COVID-19 run rampant, you're going to have deaths among our most vulnerable. And I think also, as Doris will speak to, that segmenting communities as a strategy, it normalizes exclusion from society of our older adults. That's not ethical. I would argue it's ageist. And it really erases decades of work in disability activism where we have tried to avoid strategies like this, and it should not become our default response here. And so without a strategy to suppress community transmission, and as Dr. Fandala says, strive for elimination of COVID-19 as our goal, we're going to be committing residents and many other older adults to indefinite, harmful, and deadly confinement. And I always show this photo. It's actually from Barcelona. This is supposed to be sort of, the innovations that we have during this time of a hugging curtain. But this is heartbreaking what's happening to our older adults, not only the deaths, but the conditions that we are imposing on them because we are not taking action to suppress community transmission and really get this under control in our province. And we have to think about, why is this the case? Why is it that we are not identifying with the data that I've showed you? Well, this is a piece written in one of the most eminent medical journals by Scott Halpern at the University of Pennsylvania. Humans respond more aggressively to threats to identifiable lives, those that an individual can easily imagine being their own or belonging to people they care about. or care for. The reality is most people don't identify with the lives in long-term care homes. And if you look at the language that's being used to drive public health policy, the language of balance, there's a lot of identifying with small business owners and the economy, and not as much identification with the vulnerable older adults who are bearing the brunt of this pandemic. And we can't also forget that residents of long-term care homes face multiple and intersecting forms of discrimination. There's ageism, the majority of them are older adults. The majority of people who live there are women, so there is gender-based discrimination. And the majority of people, as I've discussed, have dementia, so there's dementia-related discrimination. And as Doris has pointed out since day one, the majority of long-term care workers are women and many are people of color. And is that plaguing our response in terms of paying these workers fairly, providing them with the conditions of work that incentivizes them to work in long-term care and to remain in the workforce? And finally, the structural ageism. So I think the hardest thing for people like Doris and I to watch is the complacency to the ongoing loss of life and the complacency to what is going on in long-term care homes. If older adults, this article was just published in JAMA Health Forum, that the pandemic has forced us to see how we value or devalue the lives of older adults. And if older adults were valued equally, arguments to compromise public health for economic reasons or resist small sacrifices of personal autonomy would ring hollow. And I really question if that's what's driving the inaction we're seeing with the numbers that are being presented by multiple different sources, and why we are failing to act to protect older adults and those in long-term care settings. So I'm going to hand it over to Doris, and thanks for giving me the opportunity to present some of our data and my thoughts on what is going on.
Thank you, Nathan. And I hope that people can see the slides. Can they? If you can put the first slide, PG. I still don't see if people can see the first slide. No, not the first of Nathan. My first slide, PG. Or give the control. I think they were able to see, but I cannot move them again. Oh, here we go. I am going to manage them. Thank you. Let me manage them. Thank you. Can people see the slides? Yes? Fantastic. So before I start, and I thank Nathan very much for joining us, I want to thank a second group of people, three groups of people. First, and Nathan, you mentioned Dr. Jakob Michael, Sue Gowens, and others like David Fishman and others that are ongoingly collecting data, and from day one, even when things were not transparent and public, they have made them public. So kudos to you, because without that, we would not be able to do a lot. Second, I want to thank the media. The media, and I have the vision of SARS in the back of my mind, whereas I was very involved too with RNAO. The media has been absolutely incredible in the courage, in the pointing issues, not fingers, but issues, in asking the tough questions, and in bringing that voice forward. And I want to say, whether it's Bruce Arthur or Laura Stone or Liz Brown or so many of you that really, I couldn't help it but make a public shout to some of you yesterday. Thank you for that. Without that, again, the voices of Nathan and mine and even other people that are doing data would be silent, because you are the connection to the public. And with that, I also want to thank the seniors that are joining today, the families that are joining today. We absolutely know at RNAO, because we work with you day in and day out, how excruciating this has been for you. And you give us actually the strength and the energy to keep pushing forward. So please know that. Don't thank us. Know that you actually give us the energy. I want to build on the last remarks of Nathan. Structural ageism and discrimination. And let me give you two figures, because, and I'm talking about Canada, not the entire world. We know that people are frail, that people are more ill, and that people in nursing homes have a bigger chance to not make it through COVID. But how do you explain that in the rest of the OECD countries, is between 38 to 40% of people that have succumbed to COVID-19. And we have the horrible distinction of ranging between 78% to 81%, depending what do you look. That is absolutely structural ageism. How do you picture or explain that amongst workers, we have much, much higher numbers of people that have contracted the virus? Just as of September 1st, and thank you, Dr. Jacobos, for giving me this information. Just after September 1st, 2,100 seniors and 1,500 staff have contracted the virus. How do we explain that? Yes, of course we know, and building on Nathan's comments, that is, we know that these are racialized communities. These are communities that live in more crowded places likely. These are staff that have used to have 3 jobs, so we're running, and some of them that work for agency, by the way, still have 3 jobs. So this ought not to be a surprise. My question is, first, to Dr. Fullerton. She has a medical background. She ought to have known that this would have been the results in the first wave, given what was happening in Europe and other places. And she ought to have known that this would be the results in the second wave. And we will show more data and more explanation of what has happened in the summer and what has not happened. And next, so in the first wave, you can see this tremendous slide that Dr. Fisman has used many times and you have seen, where we began to control community spread, and nursing homes and other vulnerable populations continue to go up. Now, this is the general situation now overall where we are trending overall in this province. And look at this. This is what's happening now with nursing homes. This is what's happening in long-term care. Very fast approaching, much to the dismay of all of us that are passionate, and of families and of residents and of their staff. We are heading once again to a disaster that hopefully will not be as awful as it was the first round, but I'm not sure it will not be. In fact, I fear it will be even worse unless we act today, not tomorrow, not in a week, but today. So reuniting families is something that RNAO, listening to the families, fought for a long time. And this is the one piece where I actually credit the office of the Premier, not any minister, but the office of the Premier, and in particular, Rana, that works with the Premier, of helping us bring the voices of families. And I hope Sue Nielsen is there, and I hope Robin is here, and many of the issues of families that we brought directly to them, and they listened to it and they push forward with it. This is one piece that must be recognized, and now we are saying essential caregivers must be kept in, whether it's in homes with COVID or homes without COVID, they need to keep in. So what has happened since the summer, and what improvements have we seen versus wave 1? So yes, we are doing better with PPE. There are some shortages of N95, but not significant, but overall, we are doing better with PPE. Yes, we are doing better with testing, and yes, we have families in. Where are we failing? No action. No action on the issue of staffing. 0, nil. All the promises, all the acknowledgements about 4 hours of worked hours of staffing have been only empty promises so far. There has not been funding release. There has been no directive to hire. In fact, in the area of staffing, the situation is worse. Why is it worse? Because we had wave 1. People are exhausted. The schools are open, so things may happen to children, and workers need to stay home. People are quitting because of fear. So the situation on staffing is not as bad as it was in the first round. It is worse. So unless this province will move immediately, and by that we mean today, and we have been asking this since 2016, this is not COVID related. This is pre-pandemic, pre-epidemic. This is back to 2012 that we have been meeting and saying we need the changes in staffing. Some of you may remember the noise that the Mind the Gap report caused. Well, that was noise that I wish governments back then and now would have acted on. We asked back then the same numbers that we are asking now. Recommendation 8 on that report is exactly this recommendation here. And yet we have not acted. Going into the epidemic, forget pandemic, I met with Minister Fullerton in person and shared that we needed to improve the staffing and gave the details about how the staffing needed to improve. Families, nurses, doctors, others have signed action alert after action alert after action alert. Over 15,000 people have said to government, we need to hire people now. We begged the government. We were all over the media, and the media was again with open arms. Hire people in the summer because comes the fall, we will have a twindemic and we will not know what to do. Because all of you remember that usually without a pandemic, we have during the flu season, hospitals are full. So we knew this will be a disaster. So this ought to be not a surprise. And for a minister of long-term care that says she has medical background, she ought to have known and she ought to have alerted the government to act and push for the funding for it. So it's not only the command table, all the various tables of epidemiologists and others, is our own minister of long-term care has medical background. And she always reminds us of that. Well, use it. Next is the reports on long-term care staffing. So I mentioned the Mind the Gap report in 2016. There is the nursing home basic care guarantee that we issued to the minister directly in June and released to the media. There is the report that the government of its own expert panel in July. And there is the letter of the commissioner that went urgently to the minister, and that quote sums it up. The Ministry of Long-Term Care should not be continuing to study the study of the study of the study. We have 35 studies in 21 years in this province, and nothing has been done in relationship to staffing. So no, we cannot wait to December. By then, we will have lost many, many more lives. Here are what people said to the commissioner. Devastating, emotional, lonely, depressed, muzzled, trapped, broken-spirited, boredom, terror. Let me tell you, if we ask the staff, and we have, whether it's PSWs, whether it's RNs, whether it's RPNs, nurse practitioners, directors of nursing, and even operators, they will tell you the same. I am going to quote one of our own people that went to help, staff of RNAO, without disclosing more, that went to help in a nursing home and said to me, I could smell the death in the hallways. I could smell the death in the hallways. You know, the media asked me yesterday, are nurses and others receiving the mental health support that they need? You may know that the Army put right away the supports embedded in the homes where they were. Well, that's not the case for nurses, PSWs, or others. They have the employee program, but guess what? That program usually applies only to full-time people. And as Nathan mentioned, the community that works in nursing homes is not your usual community. And specifically the PSWs, before the pandemic, 50% of them work in multiple employers, 3 or more employers. So they don't have these benefits, nor do they have the time, quite frankly, to call EIP for support. They need the supports right there in the home as they are working, both in terms of staffing and in terms of emotional support. So what are we asking now? We are asking for a complete 28-day lockdown imposed by the province, not each single municipality or public health officer, except for essential services and schools in all the red zones. If we don't do it now, in February, we will have a complete province-wide lockdown, unless we want thousands of people to die. And by then, not only in nursing homes, but also in communities. We want the immediate funding and directive to hire RNs, NPs, RPNs, and PSWs in all nursing homes across the province, not only those that are in a outbreak, all of them, because this staffing is required not only in tragedy times, it's required in good times too, to provide the care that people need, not only they deserve, but they need. We want essential care partners to be kept in long-term care homes. As bad as this will get, and it will get worse unless action is taken, we want essential care partners to be kept in. You know, at the beginning, we believed the first week of the first outbreak, of the first wave, we believed that we were doing the right thing. When we understood that homes didn't have the basic necessities of staffing and of PPE and of everything to keep the virus out, we said, let families in. Because number one, people don't die only from having COVID. People die from dehydration. People die because the staff don't have the time to feed, to help them eat. People die from lack of love and a willing to live. A willing. I'm not even talking depression. Any of us that have been deprived from being with our families feel that void in the heart. Just picture if you were in a room, day in and day out without your loved ones. People die from lack of love of their own families, their own friends, and by that I mean their chosen families. And we're saying urgently decrowd nursing homes with residents in multiple occupancy rooms, which we still have. We still have homes where you have 3 and even 4 people per room. And we still have, by the way, workers that are working in multiple facilities. Agency staff are working in multiple facilities. That got to stop. It stopped during SARS, it got to stop now. So we say to the minister, to the premier, and to everyone, the announcements need to come out today. If the announcements don't come out today, please know, and the premier is pretty aware because we met this past Monday, face-to-face, RNAO will continue. The next round will be a major rally for seniors unless we hear announcements now. We cannot afford to wait till the minister, and I refer to Minister Fullerton, brings her staffing plan in December. This is not a Christmas or Hanukkah or any other holiday gift. This is what residents need now. These are lives lost. These are our communities, our parents, our friends, our spouses. The action is needed now. And I, for one, feel ashamed. I feel ashamed as a health professional on behalf of all my colleagues at RNAO, that with all the efforts that we have put and all the exhaustion of the efforts, we have not succeeded to move the needle where we want. And I know people that work in the front lines, including people like Nathan, people like my colleagues, my own president, who is now director in a nursing home, Morgan Offord. We know, And we know that for the families, this is suffocating. The fear that your home is the next one that will have an outbreak is real. And for those that the outbreak is already there, the fear of both not serving your residents, not serving the families, and being afraid of contracting the virus yourself and bringing it to your families and communities is real. So the action is needed now. And the other action that is needed now is each one of us as individual citizens taking action of doing what is right. The fact that government doesn't move with what's right doesn't mean that we should not start to move. The distancing, the not going to crowded places, the masking, the not mixing families or households, all the things that by now we should be able to rhyme like the multiplying tables. We need to act on that. We will open now for questions and comments. First questions from the media and then comments from anybody else that is here. And we really thank the over 100 people, 120 people that are in attendance. Thank you on behalf of Nathan and myself and everybody, RNAO of course, and Sinai and all the organizations that everybody represents. If you want to unmute the microphones of media, PG, please. Thank you. Or if media puts their hand up. Did I lose PG?
I have a question, if that's okay. It's Elizabeth Payne from the Ottawa Citizen. We heard yesterday projections that going the way we're going, the province could see over 6,000 deaths. I'm wondering, Dr. Stahl, what that could mean in long-term care homes in your view.
So I think the projection was 6,000 cases a day, right? Yes.
Yes, I'm sorry, yeah.
Yeah, so the projection was for over 6,000 cases a day by early December. I mean, our study clearly showed a strong relationship between community incidents of COVID-19 and COVID-19 outbreaks. You know, and this is not unique to Ontario. This has been shown in multiple jurisdictions across the world. You know, what we're dealing with here is, you know, people keep asking to compare the first and the second wave. The first wave, you know, relatively well. The community transmission was relatively well suppressed, and homes were totally unprepared. I would argue that homes, like Doris has highlighted, we've shored up personal protective equipment for the most part, testing. You know, there's a greater understanding of the fragility of the sector. There's a greater understanding of the transmission of the virus. But even with, you know, without addressing the staffing issues and with the insane levels of community transmission that we see approaching us, I hate to say it, but I agree with Doris that we may end up seeing a situation that's worse than the first wave. If we allow it to get to 6,000 cases a day, which will totally overwhelm our healthcare system, it will cause probably more devastation than we saw in the first wave in our long-term care homes. It's a horrific thought. It's a horrific thought.
And if I may add, Liz, what we will also see is a much, much larger number of staff that will die. If the community spread is allowed to go to the levels that already is going, and if action is not, hence why we are asking for the 28 days of lockdown except for essential services and schools. Because if not, this will go rampant. We will not be able to control that, as it has happened in other countries. I think Nathan is much more generous than me in relationship to the first wave. I can tell you I was involved from day one, before it was a pandemic, with Dr. Williams, with the deputy, with the premier, with everybody. And I was reporting to them because of RNAO's work on evidence-based guidelines. I was reporting to them what was happening in China, then what was happening in Italy, then what was happening in Spain. We didn't have a good excuse to start so late in wave one. We could have started much, much earlier. So that set us in the wrong direction. Now we have zero excuse. We already went ourselves through our wave. We know what works and what doesn't in terms of breaking the cycle, curbing the, whatever we want to call it, we know what works. And the measures that the government put in their current framework are nothing but, I will quote David Fisman, media hygiene or hand hygiene or however he calls it, but they're not real measures. They're too soft. And if you look at my tweet that I pinned months ago in September, we were asking already to close the bars, period. The COVID doesn't take a break, at certain time. COVID doesn't take a break in gyms at certain time. It's very clear what are the three factors now that really increase, right? The 3 C's is very clear. So if action is not taken now, we are in for a disaster in nursing homes and overall in the health system, both for not only older persons, but much younger than that.
And let me be clear, Doris, the level, we all know that the level of cases we're seeing today is reflective of behavior 2 weeks ago.
Exactly.
Even if strong action is taken today, we are in for weeks of really devastation, irrespective of strong action that might come, because we have already let it get out of control. So, the actions that Doris is calling for not only pertain to, preventing, the damage has already been done to some extent, and we are going to incur it for a few weeks now, irrespective of what the government chooses or chooses not to do, hopefully today, but most immediately.
The damage has been done, and it will be a complete disaster if we don't act today. A complete disaster. So we predicted that RNAO, a complete lockdown of the province in February, if not before, versus the hotspots or the red spots. Other questions?
I have a question. It's Chelsea Nash from rabble.ca. And I'm just wondering, this week, the provincial government announced it would be recruiting people who are unemployed or displaced from retail or hospitality sectors, administrative roles, or are students in education programs. And it wants them to re-enter the workforce in long-term care as a new class of workers they're calling resident support aides.
Yes, with a few days of training.
Yeah, would having these workers in homes help or hinder the situation?
So,
they're clearly not trained as PSWs or RNs.
So let me be very clear. The time for Band-Aid solutions is over. It was over actually in April. We knew what happened. A person trained for 2 days under the Missionary Institute, with all due respect, or 3 days, because I think after we complained, they increased the training, but it is just a few days, can never provide what PSWs that are trained more, what RNs, RPNs, and nurse practitioners need to provide. So no, we will stick with the basic care guarantee, which is 48 minutes of an RN per 24 hours, 48 minutes in 24 hours. If that's too much, then let's go home and don't say we care for seniors. 60 minutes of an RPN in 24 hours, 132 minutes of a PSW in 24 hours, 1 nurse practitioner per 120 residents. We know that the 60 homes that have nurse practitioners perform better during the first wave, and we need 1 IPAC person in every single home. We need to build the capacity of the homes, and we need the mental health support, etc., in the home. Not just hospitals have full armies of people to serve, and we kudos that they have them. We should not depend on Band-Aid solutions. The army, the Red Cross, the people from hospitality sector to come. It is time to take it seriously and deliver on the 4 worked hours of care that we have been asking. RNAO has been asking forever. The own commissioner said that to the minister now. The own report from the minister of our expert panel said it too. Time to move with that. We are not going to support any band-aid solutions anymore.
Thank you.
I have a question.
Yes, please.
It's Mike Adler from TourStarsToronto.com. I was listening to an executive director of a home that's in an outbreak talk about the lag in testing of the employees, saying it takes a day or two to get the test results, even if they are testing. It would be very, very helpful to have point of care testing. We're supposed to have these rapid tests in Ontario now. Does anybody know where they are and when they're suddenly when they're actually going to be used? Long-term care.
Nathan, do you want to take it on? I can build on what I hear from the field also.
Well, I absolutely agree that test turnaround time, actually not just in staff, but also in residents in outbreak settings, has hindered outbreak management response. We've heard that time and time again, that waiting days in some areas where they have respiratory symptoms and they are not getting the results back. I think that even with current lab capacity, let's put aside the rapid antigen testing, that the long-term care workers and long-term care homes, the resulting of the test needs to be prioritized clearly for this population. I would hope when the rapid antigen testing becomes available in the province that these are also prioritized for the sector. I don't have any further insights into the availability of when these are coming beyond what has been publicly reported. I'm not sure if Doris does.
No, as of yesterday, we didn't have news in the collaborative table, so I don't know more than you. I do want, though, to make the comment, is not saying that what you just heard is incorrect. Our hands on the pulse, though, still show that it's much better than the first COVID outbreak. It was a disaster back then. I mean, staff didn't get tested, Mike, didn't get tested. Staff had work in quarantine, if you remember, and that was a directive that they could be working unless they had symptoms. Right. That has come down significantly. So we are actually now surveying all of the homes with our coordinators to actually be assured of that. But we hear that all in all is better, significantly better than on the first round. Of course, the rapid testing will make it just hugely better also for surveillance testing. So not only when you have an outbreak, but actually to surveil, because remember, many people are asymptomatic, right? So if you can do a bit of surveillance testing, as some have recommended from day one on the first round, we will be in a better place, especially given the community spread that is out of control almost.
But let me be clear, the modeling study shows that you need to test at least twice a week to be able to prevent outbreaks when community transmission is high. So, serial testing of workers and long-term care home residents is no solution to all the other things that needs to be done, and could also overwhelm our testing capacity in the absence of having rapid antigen testing. So I would, the primary thing, as Doris and I have highlighted, is we need to get community transmission under control, and we need to address the other structural issues in the home. Testing may be one component of it, but at that testing frequency, it's going to be, the practicality of it is going to be a challenge.
I want to address for a minute, if I may, the discussion about for-profit and not for-profit, because I want to give you a bit of where RNAO stands with that. Let me give you, to build on the data that Nathan shared. So The study that the Toronto Star did with 3 investigators that came out, I believe, this morning, should come not as a surprise, and thank you to the investigators that did the study. For-profit long-term care homes, once again, are seeing significantly worse outcomes in Ontario in the second wave. And that was done by Kenyon Wallace, Marco Crown, I believe, and one other colleague at TAP. LTC facilities experiencing outbreaks, they experience outbreaks at about the same rate, meaning the virus can get to the home more or less at the same rate, regardless who runs them. What is different is what happens once the virus is there. For-profit homes struggle more, and it's very clear to us, and was on the first wave too, to control, to stop the spread of the virus. Residents in for-profit homes are 3 times as likely to catch COVID-19 as those in a not-for-profit facility, and 3 times. And for-profit homes have seen twice as many staph infections per bed. In homes experiencing an outbreak, for-profit homes have seen nearly 10 times the number of fatal cases per bed than not-for-profit homes, and nearly twice that of municipal homes. So the for-profits, the not-for-profits do better, the municipal do next, and then is the for-profit. Yet RNAO is not calling to take over all the for-profit homes. And you may ask yourself why when we know this data. Because no government will be able to do that. What are you going to do with all the residents? What we are saying is, what are the basic standards? This is why we are calling. This is at the essence of the long-term care nursing homes basic care guarantee. We don't care at RNAO, we care, but in practicality, pragmatically, you are for-profit or not for-profit, this is what you shall deliver. 4 worked hours, meaning vacation, sick time is not counted on that. 4 worked hours of direct clinical care by the staffing pattern that we showed you. This is why, to the question of the colleague at Ravel, no, the hospitality sector is not counted on that, because with a few days of training, I rather have more essential caregivers there. They know better than the hospitality sector what to do for their loved ones. So let me move to other questions if there are. If there are no questions from the media, I wouldn't mind opening to to seniors, to families, to colleagues that work in nursing homes. Any questions, any comments? Are we ready for action? Because we ain't going to stop here. I see a few members of our own board saying, you see, that's the problem of the Premier. I have a board that says, go bigger, get it done. So thank you to my board. Yes, Helen, please.
Doris, could you comment on the number of nurses that are available to go to work?
Thank you. So the Premier called me, this is not the meeting we had on Monday, but I repeated that on Monday. The Premier called me a few weeks ago, right before the closure, before Thanksgiving. And we had a conversation, and one of his questions was, Doris, do you have enough RNs? And my answer was, yes, Premier. We have enough RNs, we have enough RPNs, we have enough PSWs. Tell your people to ask. Well, to this day, no one has asked, Ellen. Mm-hmm. So yes, do not buy for the media. For Laura Stone and others that go to, the press conferences, Bruce and others, don't buy it. Don't buy that there is not enough stuff. There is not enough staff to do the full enchilada of the 4 worked hours, but to do 3.5, there is staff today waiting, including people like Helen and others that offer themselves. You may remember during the first wave, we launched Via Nurse. In Via Nurse, we had RNs, RPNs, PSWs registered. We deployed thousands by request directly from nursing homes, of even to homes in an outbreak. We had a special category, Helen, of people that are willing to go and work in an outbreak. So I offered to the government to reopen Via Nurse. No one has asked. So that's the answer, Helen. There are people that are ready to work like you and others. And there is no excuse at all to wait till December to put a staffing plan. There has been a staffing plan since 2012 ready to go. There is the own plan that actually the expert panel of Minister Fullerton did. The time for action is today, and I am now pleading directly to the Premier to enact today the 4 worked hours per resident per day in all nursing homes across this province, starting with the ones that are in more difficult situations, but all of them.
Thank you.
Any other questions?
Hi, Doris. It's Ian Sheriff Scott from iPolitics. Can you hear me?
Yes, perfectly.
Do you mind if I ask a question?
Oh no, absolutely not.
Yeah. So I found something interesting that Nathan brought up about the bias in policy making and how we how those making the policy struggle to, for example, relate to those in long-term care versus business owners. So could you maybe give me a sense of how we might go about shifting that and changing the way that that bias impacts our policy making?
If I may take a stab and then I will pass it on to Nathan. Discrimination and structural discrimination and systemic discrimination is nothing new. It's the only new thing is that COVID-19 is putting it on the mirror for everybody to see. That's the only new thing. Come the winter more, you will see probably similar struggles in shelters. You will see struggles likely in jails. You will see struggles in other areas where there are vulnerable populations, indigenous communities. This is not a new phenomenon. What is new is that now we're saying it out loud. And in the area of long-term care, there is 2 types of discrimination. One is the so-called ageism, right? Well known, well written about, nothing done about it, except by people like our organizations and others. And there is the one against the staff. We absolutely know who are the staff, especially when you're talking about PSWs. Many of them who were nurses in their country and here they cannot make it and they start to work as a PSW simply because they need the means to make a living. But we know they work in 2-3 places, they're poorly paid, they don't have benefits, and therefore they cannot speak up also. So then when you cannot speak up, that only strengthens the discrimination that they experience. So how do we tackle that? We actually scream about it. We say it, we write, and we speak about that, and we force change. We now have a task force at RNAO that is on the issue of anti-Black racism. And I'm not going to go in details except of go to our website, but my immediate past president, Wave Angela, and Corsita, who might be there too, they co-chair this task force, and we are going to clean up our own house, please, first, inside our own profession, all the institutions in our profession, from RNAO to ONA to the college to universities, etc., etc., etc. This is no different with the workers in long-term care, except that it is somehow okay. And we are saying it is not. And the article, Nathan, that you mentioned, it will be great. I read it yesterday too. It will be great to put that in the link. If not, we will send it to people and in our website. The one about structural, right? It is structured. It is, and it is structured in a way that will stay there. The fact that we allow people to work in 3 places and they cannot speak up because if not, they kick them out, right? It means it's structural.
Yeah, so to build on what Doris is saying, I mean, you know, when we ask for a lockdown or shutdown, this is the option of last resort. This is not done flippantly. This is not done without a realization that there are collateral damages, and there are collateral damages to people's businesses. We should be, as a society, paying people and protecting people's businesses to stay closed to protect our population's health at this time. And we know from many different jurisdictions, you don't get a functioning economy and sustainable opening of your businesses without getting the virus under control. So that we do not say comments or make calls for lockdowns without the recognition of the terrible cost that this will have to people, but we need to protect those people financially and protect those businesses. And, you know, to the credit of the federal government, there have been things done to help protect with some of the subsidies that have come into place. But more directly to your question, you know, I really believe that it speaks to some of the issues that Doris speaks to. To be a little more provocative, perhaps, you know, the people who live in long-term care, in addition to discriminations that they face, they don't themselves have a lot of political power. Many of them may not vote. They have limited life expectancies. They may not be alive for the next election. But small business owners probably are going to be, for the most part, and do hold a lot of political power with this government and a lot of political capital. If you look at on a daily basis where the press conferences are held, they're not in front of long-term care homes that are the government press conferences, the daily briefings. They're in people's small businesses, they're at workplaces, but they're not in front of long-term care homes that are fighting outbreaks. They're not with the frontline workers. So that identifiable lives bias, it's clear what this government identifies with. They identify more with the small businesses. And I have said it, and I'll say it again, that, you know, I've showed you the data, who's bearing the brunt of this pandemic. It seems to me when they continue to say we need balance, that they accept the deaths of these long-term care residents as somewhat an acceptable cost of doing business. And that's very provocative to say, but I'm starting to believe that, and I've seen no evidence to the contrary. You know, if the press conferences started happening in front of long-term care homes, bringing the frontline workers who are battling these, you know, terrible conditions, these people also need to be celebrated, but we haven't seen that recognition in the same way. And I think that sort of that identifiable lives bias that I talked about in terms of what influence public policy seems to be what's playing out in our province right now.
I want to add another comment that I mentioned to the Premier this past Monday. The myth or misguided communication that it is either or, that you either protect the health of the public or you protect the income of businesses. It's misguided. And by now, no politician should believe on that because they know how it works and because we had the first wave. They go parallel. They don't go like this, the virus and the economy. This is the virus, and this is exactly how I explained to the Premier. This is the economy. This is the mental health of people. This is the social lives of people. If you don't suffocate the virus soon, you are only going to prolong the suffering of the economy, the social gatherings, the being together as families, and in the process, we will have more illness and more death, not only in nursing homes. If we don't act now Nursing homes will be the worst, no doubt, because it's a population that if you don't keep the virus out or control it right away, that's it. It takes like fire. But we will see that in shelters. We will see that in incarcerated people. We will see that in our indigenous communities. And we will see that in our own communities amongst people 50, 60, 70. It will be a disaster. And to think that this will improve by keeping this open a bit and the other open a bit and the other open a bit, doesn't work that way. If you don't break it now completely, we are in for a terrible, terrible time, colleagues. So unless there are other questions, which I will, but before people start to depart, I do want to thank the media, because I said to Sean Jeffers that we were talking 2 days ago, and today he's off, so he couldn't come. But I know he's listening, and we have spoken a lot. It pained me. It really pained me. It gave me hard feelings. And RNAO, that it almost felt as even if the media was forgetting all this with nursing homes. Like people become numb. People become numb. All of us become numb when numbers. We keep going through numbers like if these are not the lives of people. So I really want to thank those of you that took the time to be here. And we plead to you, the media, to keep the issue of the situation in the province as a whole, because if the province will not act and will let only public health officers act, it will be like the masking that took forever, right? When it can be done right away. And then we get a bit more control at least 3 weeks from now, not right away, as Nathan rightfully said. And also the implications for that of doing nothing for vulnerable communities, starting with nursing homes, but not only nursing homes if we continue this way. And also our own neighbors, also ourselves, our friends. Because let me tell you, many of us didn't know in the first wave someone that had COVID or died from COVID. Well, I already know two. And many of my colleagues know. More and more and more, we will start to know people that are or are not in nursing homes that succumb to this horrible virus. I also want to say that people like Nathan, David Fisman, myself, RNAO as a whole, we know how difficult it is for politicians. We are not naive. We absolutely know, and we feel the discomfort and we feel the difficulty of making decisions. But when you understand that these things go parallel, that if you don't suffocate this horrible damn virus, we are not going to improve the situation for the mental health of people, for the social being of people, for the economic being. We know small businesses is very difficult. We see it in our own communities. I live in East York. I see it in our own community. But we're not going to make it better by doing nothing significant now. We will only going to make it worse for them in the long run. So again, I don't know if there are other questions. We are open to answer. We don't want to cut the questions off, but I was afraid that some people may start to leave, and I wanted to say thank you for the media for keeping this alive. We need it desperately, desperately. And that framework, by the way, needs to change today too.